Welcome to the third Personalized Surgery podcast. We're very excited today to have Dr. Suraj Hindiskere from SPARSH Hospital in Bangalore. Dr. Hindiskere has been in Orthopaedic Oncology and has done his MS Ortho and DNB around this. He has experience in learning from India, Italy, as well as South Korea. It's an honor to have you, Dr. Hindiskere.
Thank you.
Welcome.
Thank you very much. Thank you for the opportunity, Mr. Ketan. It's nice. Hope that it's fun because he's someone that I look forward to because he's got the experience of both the worlds. He's been in Stryker for such a long time. He's worked with Materialize. So if there is someone who should be talking or heading the 3D printing sphere here in India, especially in the orthopedic world, then no one better than him. Thank you for the opportunity.
Thank you. It's an honor. So, share with us your sort of a first encounter into this 3D technology when you were, either learning or has been part of this orthopedic oncology.
Yeah, so 3D technology, we have been getting the CT scans done with the volume rendering images of the area of focus for quite some time, but they've always been on the screen. They've never been off the screen. So this was even during my postgraduate days about 10, 15 years ago. So we used to get the 3D rendering done, but then it was not, made for the surgeon. It was basically an extension of the scan which the patient was getting done. But I would say about 7 to 8 years ago is when we started actually using the 3D printing technology to understand the patient's anatomy better and better. So usually in orthopedic oncology, whatever advances or technological changes that are seen in orthopedics, we slowly, mainly in arthroplasty, I would like to say, we slowly adapt into orthopedic oncology. But unfortunately, when it comes to 3D planning and 3D printing, this didn't happen. About 8 years ago in Korea, National Cancer Center, Korea, I had a professor I knew pretty well, Professor Kang. So he was given by the Korean government. He got a grant of about $1 million US, I think, to spearhead 3D printing, to design implants, and to start using them in patients with orthopedic oncology problems. So that was kind of my first thing when I was during my fellowship days, is when I started seeing this technology of 3D printed implants, and slowly this was also started done in India. Me along with Dr. Pramod, we started working with a lot of companies where we first got the 3D rendering done, 3D designing done to understand the anatomy better, and slowly ventured into printing 3D models, and then slowly started designing 3D printed implants. So I would say roughly around 7 to 8 years is when all this has taken off here in India, at least.
Yeah. So share with us, like when you were in Korea, when you were firsthand, when you saw all this, like what was your first reaction? Like, was it?
Yeah, it was mind blowing because everything was new. Like I told you, we did not have experience or exposure to this technology when during our postgraduate days. So everything was new. And back then, even in arthroplasty, I don't think custom-made 3D printed implants were being used in revision surgeries.
Right.
So even in any other branches of orthopedics, this technology was not commonly used back then. So, and because it was so very new, it was mind-blowing to begin with. And next thing was it was personalized, like how the intent of this podcast is personalized. So it was not an implant or a technology that could be used in all patients. So every patient needed a different solution. Every patient needed a different implant. So it was truly a personalized solution. So because of these two factors, it was truly mind-blowing to come across this technology. And we are very happy and proud that India has adopted this technology pretty fast when compared to the West. We have not lagged behind, like how it usually happens when it comes to adapting newer technologies. We have taken it up pretty soon, is what I feel.
Yeah. So question around like oncology, and I have a lot of respect for the orthopedic oncology surgeons, because the brutal surgeries that you go through, and the patients are so much younger, and many a times, like it's like the cancer is growing very fast, right?
Yes.
So how do you balance between, say, do I go with the surgery, do I do a medication? Maybe if you can share a little bit, that would help.
Yeah, that's That's a very unfortunate story. Every day you open the newspaper, you might hear about immunotherapy, targeted therapy, stem cell therapy. A lot of advances in medicine has been seen in the recent past for a lot of solid organ tumors. So just about 10-15 years ago, a lung metastasis stage 4 lung cancer patient wouldn't survive for months. But these days, because of targeted therapy, which is basically medicine, the survival has drastically increased. But very unfortunately, in orthopedic oncology or in soft tissue sarcomas, we are following the same chemotherapy regimen which was designed in the 1960s, more than 50 to 60 years ago. So there hasn't been a breakthrough or drastic improvement with respect to chemotherapy or the drugs, which is in orthopedic oncology. So the only thing which is helping us to make the patient's life better is technology, meaning surgical advances. So medical advances are not so much. So because of better imaging, better MRIs, better understanding of the tumor extent, better surgical procedures, robotics, 3D printing, all these technologies have helped us to do better surgeries. And another thing about orthopedic oncology is we are handling two things. One, we are treating the cancer. We're basically trying to take the cancer out of the body in a good way, such that it doesn't come back or doesn't spread to the other areas. The other thing what we have to balance is functionality in orthopedic oncology. Despite not only removing the tumor, we also have to make sure that we make the patient walk or get back to the functional aspects, what they want to, what they were used to. So to do this, to make sure that we give the patient the best possible functional outcome, we have to make sure that our resection is good and reconstruction is equally good, if not better. So this is a slight difference in orthopedic oncology when compared to either routine orthopedics or other forms of cancer.
Yeah. And you mentioned about like resection and reconstruction to get patients to a normal life with so much changes in physiological changes, biological changes that happen with these removals, right? So if you can maybe share a little bit more about, so in the surgery there are multiple different options, right? So I think the whole technology is really moving in a way where biological fixations are happening.
Yes.
There are multiple different options, like there will be like some sort of radiation with ECRT, or they do liquid nitrogen or polymer based implants or metal implants. Even within metal implants you have these growing implants, so that in younger patients, juvenile patients, if the growth plate is not there, then these kind of implants kind of take over and all. So maybe if you can shed some like how do you choose, right? What decides what you use?
Okay, so when it comes to reconstruction, we can broadly categorize it into biological reconstruction or non-biological reconstruction. In biological reconstruction, we try to use biology, that is bone itself. We take out the cancer segment of the bone, we treat it with different things like radiation or liquid nitrogen, we kill the cancer cells. The same bone, we put it back into the body. Or just like how we get money in the bank, we have bone banks where we get someone else's bone. So we take that bone, we shape and size the bone to match this patient's anatomy, and we put it into the body. So in both these cases, we are replacing bone with bone, either dead bone or someone else's bone. So this is called as biological reconstruction. The other part is prosthetic reconstruction, where you don't use bone, we use metal implants or a polymer based implants. Usually it's metal implants, and we replace it. So in children, I personally prefer biological reconstruction because they have their own challenges. The metal implants obviously don't grow, they don't become bigger. And the children's bone, they grow, they remodel, they change their shape and size. Because of all these things, these metal implants usually don't last for a long time. This is a general idea. But these days, because of improved metallurgy, we have implants with so much of osseointegration, meaning the implant can integrate into the patient's anatomy or the bone so well that they last for a very long time, 15 years, 20 years, if not more than that. Second thing, like you rightly mentioned, we have growing or expandable processes which can be made to grow or become bigger as the child ages. So because of a lot of, again, technological advances, the change in different types of metals, better metallurgy, better polyethylene. So even metal or non-biological reconstructions have been doing pretty well in children. But yes, non-biological reconstruction is better. But they also have their own challenges. Whatever bone we use, it's a dead bone. It's not a live bone. So it can fracture with time. It can get resorbed. So even they have their own challenges.
Awesome. Amazing. So, I've seen you use the AR/VR technology in the surgery.
Yes.
How does it really help inside the surgery?
Oh yes, that's an exciting new technology. So when we get the 3D modeling done or design a model of the patient's anatomy, so we have multiple options of how we can utilize it. One, you can see the same 3D model on a computer screen. So let's say that I want to touch it, I want to feel it, and I want to actually use it during the surgery. We can actually get it printed. So the advantage is I can sterilize this and then I can use it during the surgery. I can see how my the plate sits, how much of the bone I need to remove. I can make all those planning. So this is a 3D printed bone. So next comes our VR surgical planning, where we wear the VR surgical glasses and then we try to see the patient's model with the VR glasses. To be honest, VR glasses is just a fancy computer screen, because whatever you're seeing on the computer screen, you're looking at it in a VR 3D environment where you're able to rotate, zoom in, measure. You can do all the basic functions, but still it's a glorified computer screen. The actual step up is the AR, which we have been using for quite some time. So AR, you can see the same patient's model in the environment in which you are in. So let's say that I'm in the operating room, I'm looking at the patient. Side by side, I can see the patient's anatomy much clearer, much better. I can rotate the patient's pelvis. I can zoom into the tumor. I can see how far the tumor is from the vessel, from the nerve, while I'm seeing the patient simultaneously on the operating table. So this AR is truly a game changer. So how has it been? How has it been helping the surgeons? Again, to understand the anatomy much better. We can virtually do the surgery before doing the surgery. We know what structures are at risk, what structures can get damaged, how to save them, how to save the important anatomical structures. All these things I can do it in my head before even cutting open the patient. It makes a lot of difference to understand the patient's anatomy as much as possible before I put the patient's knife, because there's no surprises. Once I go inside, I know that these are the problems I'll face, these are the ways to get out of it. So I can plan the surgery much better with this AR technology. Or we could do it even without AR. I could sit in the radiology room or in my OPD and look at the scans beforehand and then go into the operating room. Even in the operating room, I can switch on the computer and then do it. But then doing it in 3D while I'm operating is truly a game changer, because I just understand the anatomy so much more better. And because of our 3D lab, because of the SPARSH 3D lab which has been set up by Jajal, we have all this facility in-house. So I don't have to wait for days together to get this done. So we can do it virtually, like overnight, once the patient comes to my OPD. In fact, we have a phrase here. We say that scan in the morning, plan by noon, print overnight, and execute next daylight. Nice. So it's that easy with the 3D lab in-house. The patient walks into the OPD this morning. I can get the scans done. I can get the segmentation done. And then overnight, we can get the models printed. And then next day I can start using it. It's not like just 3-4 years ago where I had to wait for days, if not weeks, to get all these done. So it's really a game changer to perform bigger complex surgeries much better.
Amazing. No, so the AR, basically, you can see in the screen, you can have the model next to the surgery, in the surgery. But what I'm saying is, with this AR, now you are able to overlay that exact anatomy of that patient on top of that same location to give that perspective, which is 3D, which gives you a much more better surgical guidance during the surgery.
Yes, definitely. So the patient is on the operating table. The patient's pelvis, let's say I'm operating on the pelvis tumor, patient's pelvis along with the tumor can be overlaid on the patient who is on the operating table. So I'm basically looking at the tumor even before the patient is cut open. So that makes a lot of difference, mainly because I know how to position the patient, how much I have to cut open, what are the important structures I need to save. So it's not like seeing it on the computer screen. It is the patient's actual tumor on the patient without cutting open.
Amazing. Yeah, cool. You have some amazing cases. We would love to kind of learn about some of those.
Sure. So just give you a few examples. So this was a patient with a tumor in the pelvis. If you can appreciate, the purple color part is the tumor. So we have a lot of different kinds of printers in our lab. So the beauty of some of them is They have multi-filament printers where, let's say that you want different structures to be printed in different colors. It's very much possible. So this is one such example where the tumor is in purple color. So the problem in this patient was the tumor is very deep into the pelvis and it was very close to these blood vessels. So the red color thing is basically the blood vessels or the artery which was surrounding the tumor. So, and it was also close to the nerves. So if you can appreciate the yellow color portion, that's basically the nerves. So when I have to remove this tumor, there is going to be damage to these blood vessels and the nerves. So to minimize that complication, if I have this next to me when I'm operating, it makes a huge difference. I understand where the tumor is arising from, where the vessels need to be ligated or pushed aside before removing the tumor. So this is a must in all my pelvic surgeries. Whenever there's a complex case, there's no doubt that I'll be needing a printed implant. So, and this is one such example, and this is one more example of a small boy. This is an interesting case actually. He had a bad osteosarcoma of the distal ulna, which was not treated properly initially because they thought it was infection. He's undergone multiple surgeries. He had a huge fungating mass, and because of the extent of the tumor and so many blood vessels all around the tumor, so he visited multiple hospitals in Delhi, and they told that the only solution is amputation. We have to cut the arm. So then the patient came to us, chemotherapy was started. Fortunately for the kid, chemotherapy worked very well. The tumor became small in size, and then we had to plan a complex resection. So this not only helps me, but also the patient and the attenders. So when I'm sitting with the patient's family members like this, and I tell them that, you know what, I'm doing this surgery and these are the structures at risk, it is very difficult for the patients as lay persons to comprehend or understand what kind of surgery we're doing. Let's say that I do the same counseling with this 3D model next to me, and I show them that this is the tumor, this is the blood vessel which is around the tumor, this is at risk, this might get damaged, and this can happen, this is what I'm doing. They understand the complexity so much better that a lot of times these days, the patient themselves ask for it.
Yeah.
So to give you another example, so this is usually in my OPD. So there was a young boy with a small tumor around the distal femur. So the dad was an architect. So he was so impressed by this technology. He asked us, you know, if such a 3D model can be designed for his son's surgery as well. So though we didn't need it for the surgery, you know, they were interested in it and they wanted to understand it the way I understand it during my surgery, and we got this model printed. So it makes a huge difference not only for me as a surgeon, but also to the patient and the family members when we have to explain them what kind of surgery we are doing and why it is so complex.
Amazing. So patient awareness and understanding of what exactly is happening,
yes,
the confidence goes up for them as well.
Definitely.
For what you are doing is the right thing, because you know you're able to show them the exact replica of what is happening inside.
Exactly. Yes.
Nice.
Yes, definitely.
Last question on the future, right? So
Okay.
orthopedic oncology is I don't know if it's growing. Are there more cases, and where do you see the future? Like 10 years from now, like how would you like to see this evolving?
Yeah, so the incidence, I don't think it's increasing. Like, I don't think the number of cases of orthopedic oncology is on the rise, which is fortunate, which is good. Not people should not get cancer, orthopedic oncology or not. But yes, technology is growing at such a rapid pace. First of all, orthopedic is a branch where there's something new every single day. Arthroscopy, arthroplasty, the techniques and the implants which were used just 3-4 years ago are, you know, they're old, they're obsolete. So similarly, even in orthopedic oncology, the processes, the kind of processes which we are using, the kind of reconstructions, the planning, understanding the patient's anatomy, the reconstructions are like drastically increasing. To give you another example, in pediatric patients, let's say it's a 7-year-old boy, whatever plates which are available in the market might not fit the kid well because these implants are all designed for adults. So all pediatric patients, according to me, henceforth, you know, maybe in another 5 to 10 years, will compulsorily need a custom-made implant if we have to do the most appropriate reconstruction. There is no way we can, you know, try to use what is available. We can still do it. We have been doing it for decades, but I think with technology improving so much, and then with the speed at which we can obtain all these things, you know, overnight, if not in a few days, I think that most of the complex reconstructions in the next 5 to 10 years will be personalized. Most of the implants which we use in pediatric patients or complex areas like in the pelvis will be personalized. And another thing what I actually foresee is, yes, maybe 20 years ago, Getting an MRI scan was not the norm for all patients, and now it's changed. We never operate without an MRI. So maybe another 5 to 10 years, I don't think I'll be operating on any patient without a 3D rendered model of the area of interest. Maybe another 10 to 15 years, just like how we wear a cap and mask in the operating room, maybe all surgeons will wear some form of VR or AR goggles, where the patient's scan or the model or anything is right next to them when they're operating on the patients. With the pace at which the Beta is coming out with their goggles every day, with the pace at which the technology in this field at least is progressing, I think that this is going to be at the norm in another 10 to 15 years.
Amazing. Well, this is very exciting, and it's really an honor to have you in our podcast and hear how a young orthopedic oncology surgeon is using these technologies and seeing the future and enabling personalized surgery. We really appreciate your time, Dr. Hindiskere.
Thank you. Thank you. Thank you very much. It's more than my interest, the ability and the ease at which I'm able to adapt this technology here in India, here in Bangalore, here in my hospital, in our own backyard, is amazing. That's one of the reasons why we are pushed towards that, because of the ease at which we're able to do it. And I feel that the past 3 to 4 years, we're kind of learning every day. We're learning something new. We're trying to make something new. Thank you for the opportunity.
Thank you.
Thank you. Thank you. Thank you.